Okay, so we're going to discuss today about the antithrombotic therapy. So this topic will be discussing about the different drugs. Para siyang pharmacokinetics, pharmacology ninyo. So again, this one we'll discuss here the different drugs we try to help here in the management or even a treatment of your thrombosis. So we divide our drugs here as either anticoagulant. So anticoagulant, those are the drugs we try to prevent the activation of your coagulation factors. And we have also here the antiplatelets, we try to suppress the platelet aggregation. Okay, so the first one, we have your comedine. Other name for that is your warfarin. So that drug basically is your oral vitamin K antagonist. So this one is being administered orally. And that one try to inhibit here the activation of your vitamin K dependent coagulation factors. Our vitamin K dependent coagulation factors again this includes our factor 2, 7, 9, 10, protein C, protein S, protein Z. Okay, so those are the coagulation factors which requires vitamin K in order for them to become activated. So in order for them to become activated, it should undergo here the gamma carboxylation process. As I review, your gamma carboxylation process suppressed whereby the second na carboxyl group is being added that will allow your vitamin K dependent coagulation factors, factor 2, 7, 9, 10, protein S, protein C, and protein Z, to render them to be eventually negatively charged and allowing them to bind to the calcium in order for them to be activated. However, this drug tries to inhibit the gamma carboxylation process, inhibiting the addition of your second carboxyl group basically by inhibiting the enzyme epoxide reductase. As a review, your epoxide reductase, the one trying to convert your vitamin K hydroxyquinone to your vitamin K epoxide. Okay, so for that to undergo the gamma carboxylation process. But this drug again tried to inhibit the enzyme epoxide reductase, and therefore you could not add the second carboxyl group here, and therefore it will render the vitamin K dependent coagulation factors not to be activated. So again, this is a drug that is the only approved oral na drug, which is your oral vitamin K approved here by the US Food and the Drug Administration. Okay, this one is for use for the treatment of your post-venous thromboembolism, venous thromboembolism. And we have also here the ischemic stroke. Again, those are the presence of mga blood clot within our blood vessels. Okay, we have here monitoring of the patient on the warfarin combination therapy. So again, we use here the prothrombin time to monitor the patients on the combination or the warfarin therapy. Why prothrombin time? Remember that your prothrombin time try to monitor problem related to your extrinsic pathway. That's your factor 3, 7, diba? And the common pathway 10, 5, 2, 1. Among our vitamin K dependent coagulation factors, factor 2, 7, 9, 10, protein C, protein S, protein Z, the factor 7 is the one which has this shorter half-life. So pag may problem with that, it will be, your factor 7 will be decreased. And it could only be monitored by the prothrombin time because your factor 7 belongs to your extrinsic pathway. That's why we are using the prothrombin time to monitor the patients taking up your comadine or the warfarin. Again, you need to monitor the patient here on all the drugs used by the patients, especially for the treatment of the thrombosis because again, too much of the drug dosage or administration would eventually result here to the bleeding manifestation. Okay, gumagamit tayo ng mga antithrombotic drugs primarily para ma-dilute ang blood ni patient natin para hindi magkakaroon ng blood clot or we're able to manage the blood clot. Pero pag sobrang dilute mo naman or sobrang dilute mo because of the addition of your antithrombotic drugs, so baka magkaroon ng bleeding manifestation. That's why you need to monitor the patient. So in the case of your comadine or warfarin, we are using the prothrombin time to monitor the patients. Okay, usually the prothrombin time here is very prolonged after 6 to 8 hours after administration or ingestion, taking of the patient with a comadine or warfarin. Therapeutic dose here is being reached as soon as the factor 2 and the factor 10 concentration reduced by 50% is being achieved after 5 days. So the entire therapy here of your Coumadin is almost 6 months. Okay, so within the 6 months, how are you going to monitor here the prothrombin time of the patients? Okay, first, we give the Coumadin to the patient. And after 24 hours, to try to extract the blood and try to perform the prothrombin time in order for you to check for the clotting time of the patient. And after that one, you try to monitor the prothrombin time every day until the patient try to have here, until you try to reach the therapeutic dose. 2 consecutive na PT results within therapeutic dose. Pag na-reach mo na ang 2 araw na magkasunod na the patient's prothrombin time is on the therapeutic level, okay, try to have only the PT results monitored once every 4 to 12 weeks na lang, hindi na siya everyday. Okay, and then try to continue that one once every 4 to 12 weeks until the patient try to complete the 6 months therapy. Okay, for the reporting of the PT results, again, the PT results, we tend to report the result in terms of the clotting time, percent activity, saka INR. Okay, for the INR, desirable level here of the INR should be 2 to 3 seconds. But it could go as high, 2.5 to 3.5, the patient would have here mechanical heart valve problem. Okay, then we have also here the interference with the administration of your Coumadin or warfarin. So these are the reason actually why even if you give warfarin or Coumadin to the patient, the entire therapy is not effective. Number one, the patient is on vitamin K diet. So remember that your Coumadin and warfarin, they are antagonists with the activity of the vitamin K. So bigay ka ng Coumadin, tapos ito sa patient, kain naman, na mapagka-enrich in your vitamin K, and therefore it will not have an effect with your Coumadin administration. Another one, some of your drugs also try to inhibit the activity of your warfarin Coumadin, like in the case, for example, of your amiodarone, we have also here metronidazole, and we have also your cimetidine. Another one, this should be contraindicated for the pregnant patient because the Coumadin try to cause here birth defects. Okay, then we have here the food rich in the vitamin K. So we have the sources of our vitamin K. So we have your green leafy vegetables. We have also green tea, wine. We have also here your cauliflower, liver. So most likely if you are eating those food, expect to have here an increase na vitamin K. Remember that one will inhibit the activity of your Coumadin or warfarin. Okay, we have here the reversal agent. So basically, you need a reversal agent here if the patient would have a clinical manifestation of the bleeding. Remember that too much administration of your anticoagulant results here to the bleeding manifestation. So if the patient, for example, would have a bleeding manifestation because of too much administration of the Coumadin or warfarin, you can reverse that one by, you can give here your vitamin K, kasi diba, vitamin K antagonist ito. So you can give oral or the IV na vitamin K. So between the two, medyo mas mabilis ang activity or effect ng ating IV na vitamin K. Another one, if the patient would have also, pag hindi kaya ni vitamin K lang, then severe bleeding could also be managed by administering a unit of the blood in the form of your fresh frozen plasma. Could also have your recombinant activated factor 7 and activated factor 3 prothrombin complex concentrate. On the next anticoagulant, we have your unfractionated heparin. So this one is your pentasaccharide unit of your heparin. Its main activity, it acts here as a bridge, okay, between your antithrombin and thrombin. So unfractionated heparin try to act on your antithrombin that will allow this one to expose ang kanyang site, binding site nito, para mag-bind siya dito. And once your thrombin bind with your antithrombin, because of your unfractionated heparin, your thrombin will eventually be neutralized. Remember that your thrombin, prothrombin, does your factor 2, and therefore it will allow here, it will not allow the clotting process with activation of coagulation factors because kulang ka ng factor 2. And therefore the patient will not able to form a clot with that. So that's the action of your unfractionated heparin. Okay, so basically, this one is used here for the treatment of the venous thrombosis, venous thromboembolism, as initial treatment of your AMI. Another one for those patients undergoing here cardiopulmonary bypass operation. Your heparin is being administered to monitor to maintain the vascular patency of the patient during that cardiopulmonary bypass operation. Okay, then we have also here the measurement of our patient on the heparin therapy. So we use here the APTT, not your prothrombin time, because remember the activity of your heparin is directed towards your factor 2. And your factor 2 belongs to your intrinsic pathway. And therefore, although your factor 2 belongs to your common pathway, tama ba? But in terms of the heparin monitoring, we are mas sensitive na procedure or test procedure here to monitor that one is your APTT rather than your prothrombin. Okay, so we have here the procedure to monitor the patient on the heparin therapy. So first, okay, it's before you give heparin to the patient, try to extract the blood and try to test for the APTT. If the result of the patient is prolonged, so you need to shift that one to your chromogenic factor 10 assay. But if the patient's APTT prior to administration of your heparin is normal, then you can proceed with the administration of your heparin. Another one, so after you give heparin, the second na APTT is being performed within 4 to 6 hours, but not more than 24 hours. Okay, and then try to check if the APTT result of the patient is on the therapeutic range. If that one is not in the therapeutic range, you can adjust for the dosage. So, pwede mong dagdagan or pwede nating bawasan, provided that one is not within your therapeutic range. Then, try to monitor, basta when you are administering the patient with anticoagulant, dapat that one is within the therapeutic range. Kasi again, pag hindi na sa therapeutic range, magkakaroon ng bleeding manifestation ng patient natin, and we don't like that one. And after that one, try to monitor the APTT of the patients every day until the patient try to complete the entire heparin therapy. Okay, the problem with the heparin administration, it try to induce HIP or heparin-induced thrombocytopenia. What do you mean by HIP here? So, pag nagbigay ka ng heparin to the patient, so try also to monitor the platelet count kasi bumababa ang platelet count ni patient natin if the patient has been given with your heparin formulation. Okay, we have here the heparin resistance. Okay, again, these are the reason why the patient, even if you try to administer the patient with the heparin, bakit nawawalan siya ng activity or effectivity. Number one, fibrinogen concentration of the patient is more than 500 mg per dl. Normal na fibrinogen natin is nasa 220 to 498 lang mg per dl. Sa kanya more than 500. So with that, hindi magiging effective ang heparin administration to the patient. Another one, factor 8, concentration more than 190%. Prolonged therapy here, so just like yung antibiotic treatment, diba? So every now and then, kung take tayo ng antibiotic, time will come na hindi na magiging responsive. The same through this one, prolonged therapy, palagi mo siya binibigyan ng heparin. Time will come, the patient will no longer be effective with the heparin administration. Another one, bakit hindi nagiging effective ang heparin administration? Because the presence of your platelet factor 4. Okay, the platelet factor 4 is actually a component of your alpha granules of our platelets that's being released once your blood has been collected in your anticoagulated blood, just like your EDTA. Again, your platelet factor 4 is your heparin neutralizing substance. Okay, that is being produced by the platelets. Another one, we have your factor deficiency and lupus anticoagulants. If they are present, that also contribute here to the non-effectivity of your heparin administration. Okay, then we have here the reversal agent for the too much administration of your heparin, unfractionated heparin. So, bleeding manifestation because of the too much administration of your unfractionated heparin could be reversed by administration of your protamine sulfate. Protamine sulfate has been extracted from the salmon sperm. Has been given through a slow IV push, ganon sa IV. Okay, so protamine sulfate could neutralize 100 units of your heparin. Okay, 100 units per milligram neutralize 100 units of your heparin per milligram. Your protamine sulfate could also neutralize your low molecular weight heparin, which is the next na anticoagulant natin. Only that one, we're able to have a partial lang na reversal or activity. Okay, the next one, we have your low molecular weight heparin. Okay, low molecular weight heparin is being produced here out of your unfractionated heparin. So, galing siya dito sa ating unfractionated heparin. Okay, in terms of the activity, could also act here being heparin, so it also act here as antithrombin. Only that, less effective siya as its antithrombin activity compared with our unfractionated heparin. Its main activity here, try to inhibit your factor 10 in order for that to serve here as its anticoagulant property. So by inhibiting the activity of the factor 10. Ang advantage nitong low molecular weight heparin natin would be the rapid bioavailability. That's for 3 to 5 hours half-life niya. Okay, we have your indication. So, ginagamit natin an unfractionated low molecular weight heparin for the treatment of your deep vein thrombosis, pulmonary embolism, unstable angina, and also it's also contraindicated with the patient with the HIT or heparin-induced thrombocytopenia because it also try to cause HIT. So, kung binigyan mo na siya ng unfractionated heparin tapos bumaba ng platelet count ni patient, that's your HIT, do not give further your low molecular weight heparin because it will further decrease the platelet count of the patient. Okay, then we have here, before you give low molecular weight heparin to the patient, you try to check first the kidney function of the patient. So we have your creatinine clearance less than 30 ml per minute or creatinine level more than 4 mg per dl. So that would signify that the patient natin ay may kidney problem. And this would signify that you need also not to give, you should not give also the patient with your low molecular weight heparin kasi may kidney problem na siya because this will further damage the kidney of the patient natin. Okay, then we have here to monitor the patient on your low molecular weight heparin. We are using the chromogenic, okay, factor 10 assay instead of the prothrombin time in your unfractionated heparin. Instead of the activated partial thromboplastin time that is being utilized when you are giving your unfractionated heparin. Sa kanya, gumagamit tayo ng chromogenic factor 10 assay. This one, okay, paano siya monitor natin ang clotting time ni patient natin? So that's being given, you give your low molecular weight heparin and after 4 hours of the subcutaneous injection of your low molecular weight heparin, try to extract the blood and try to monitor the clotting time of the patients. Okay, we have that one prophylactic range ng ating low molecular weight. Low molecular weight heparin should be within 0.2 to 0.5 unit per ml and therapeutic range between 0.5 to 1.2 unit per ml. So another one na heparin formulation, we have your unfractionated heparin. So tatlo ng ating heparin formulation. First, we have your unfractionated heparin. Second, we have your low molecular weight heparin. Third one, we have your fondaparinux sodium. Your fondaparinux sodium is a synthetic heparin formulation. This won't have here much kasi heparin pa din siya. So, again, all of them would have antithrombin activity. Pero pinaka-effective sa kanila in terms of the antithrombin activity is your fondaparinux sodium because it would have here increasing the antithrombin activity by 400 times. Another advantage of the fondaparinux sodium here, we have here longer half-life, 17 to 21 hours. Okay, indications. So, ginagamit siya for the prevention of the venous thromboembolism. At the same time, just like with your low molecular weight, heparin should also not be given for the patients with the kidney problem. So, creatinine clearance less than 30 ml per minute means sobrang bagal niya na mag-filter. There's a problem with the kidney of the patients. Okay, measurements is also chromogenic factor 10 assay, just like your low molecular weight heparin. We have here the reversal. So, pag nagkaroon ng bleeding manifestation because of too much administration of your fondaparinux sodium, it could be reversed by our factor 7 concentrate. So, Nakalagay partially reversed but can help. It can help. Protamine sulfate, hindi siya marireverse ng protamine sulfate natin. Again, with your unfractionated heparin, reversal agent is your protamine sulfate. Low molecular weight heparin could be reversed also by your protamine sulfate, only that one is partial lang siya. But in the case of your fondaparinol sodium bleeding manifestation, because of too much administration of your fondaparinol sodium can be reversed only by the factor 10. Although hindi siya effective, but partially effective lang siya, but it can help. Protamine sulfate is not an agent, reversal agent, when you are giving fondaparinol sodium. But then again, the three of them, since they are heparin formulation, they act here as antithrombin ang kanilang activity. Okay, then we have also here the drugs here which try to inhibit the clotting process by our coagulation factors, basically by inhibiting the factor 10. So these are your oral direct factor 10 inhibitors. So from the word itself, their group here, they are taken orally. Okay, the first one, we have your rivaroxaban. Okay, rivaroxaban try to prevent here, it try to act here as anticoagulant primarily by inhibiting your factor 10. This includes here your free factor 10. We have also here the activated factor 10 or even your clot-bound na factor 10. Okay, this is used here for the treatment of the patients on the total knee or hip replacement therapy. Okay, to monitor the patient on the rivaroxaban, so we have here the prothrombin time, or you could also use your chromogenic factor 10 assay. Next, we have your apixaban. Apixaban, try to improve the efficacy of your patient on the comadine therapy. So, monitoring of that is also by your prothrombin. Edoxaban would have here the same activity as your rivaroxaban and your epexaban. So you're basically, again, all of them try to inhibit the clotting process by inhibiting the activity of your factor 10. So all of them, one here, belonging to your direct factor 10 inhibitor oral direct factor 10 inhibitors. Okay, no reversal agent is needed is because here, wala namang bleeding risk wala namang bleeding risk here with the administration of your oral na factor 10 inhibitors. So, wala siyang bleeding manifestation. Okay, the next one, we have the DTI, direct thrombin inhibitors. So, they try to act here as like our heparin. They also act here as antithrombin. Your DTI na group ng ating mga drugs here, again, this one could also be the same activity of your heparin, where it acts here as antithrombin. Only that, maganda sa kanya, hindi siya nag-induce ng HIT or hindi siya nag-cause here ng destruction ng ating platelets. Hindi po mababa ang platelets natin with that. The first one, we have your argatroban. So this one is being given through the IV. Okay, so this one is substitute for your unfractionated heparin and low molecular weight heparin for those patients na may HIT because this drug, they have the same function lang naman. They try to act as antithrombin, only that hindi siya nagkakos ng HIT. Reversal agent, so wala, hindi kailangan because 5% bleeding risk factor for that. Another one, bivalirudin is also DTI, direct thrombin inhibitor, which is also administered through your IV. Okay, so this is derivative of your herodine, which is derived here from the leech Herodo medicinalis or linta. So may therapeutic value ang ating linta. Okay, so this is also used here for the patient concurrent aspirin therapy. So it could have a good effect. If the patient is on aspirin therapy, then pwede mo siyang bigyan ng bivalirudin and that would have a good effect for that. Reversal agent, wala din kasi wala naman siyang masyadong bleeding manifestation. Dabigatran. Dabigatran here is an oral na DTI. So, siya lang ang oral na DTI natin. It's being taken in through orally. So, the effectiveness of this one, try to parallel the activity of your comadine and your low molecular weight heparin. Okay, for the measurement, for your argatroban, vivalirudin, again, they are being given IV that could be monitored here by your APTT, whereas your dabigatran could be monitored by your APTT, could also be monitored by your heparin clotting time or your heparin chromogenic assay. Okay, next we have here the drugs which try to inhibit the activation of our platelets. So we have here the antiplatelet drugs. So we call it once your GPI glycoprotein inhibitors. Glycoprotein inhibitors inhibit the platelet aggregation by preventing the binding of your von Willebrand factor. Example for that, we have your apcimab, Eptifi, Batide, Terofevan. Another one, we have your aspirin. So aspirin inhibit your platelet activation basically by inhibiting the enzyme cyclooxygenase. Again, cyclooxygenase is the enzyme that is needed involved in our icosanoid pathway that try to convert your arachidonic acid to your prostaglandin. So pag wala kang cyclooxygenase, it will not be converted to your further to your prostaglandin, then thromboxane A2 and will inhibit your platelet activation. Another one, some of your drugs try to compete with the STR receptor of your agonist. Specifically, it try to compete here with the STR, 7th membrane receptor of your ADP, which is your P2Y1, P2Y12. So mga drugs na ito, again, your ADP is your agonist needed for the platelet aggregation. So magko-compete sila dito sa ating ADP and therefore preventing your platelet to undergo platelet aggregation. Example for that, we have clopidogrel, plasogrel, and we have your ticagrelor. The first two are irreversible, so you could no longer able to allow the platelets to function normally. Ticagrelor, on the other hand, the activity of that is much of reversible, medyo okay siya. In terms of the two here, clopidogrel and prasugrel, your prasugrel here would have a higher risk of bleeding compared with your clopidogrel. Okay, then we have here the different instrument. We try to monitor, measure our platelets in terms of its platelet aggregation activity. The first one, we have the Verify Now instrument. Try to measure the platelet aggregation in terms of light transmittance aggregometry. Yun ang kanyang principle. Sample for that, we have Verify Now aspirin. So this one will identify the platelet aggregation response in response to your arachidonic acid. So, kaya na ba mag-aggregate in the presence of your arachidonic acid or hindi? So, ito ang instrument na gagamitin mo. Verify na, P2Y1, P2Y12, okay, will identify the ability of the platelets to undergo aggregation response to your ADP. And verify now to B3A, so that's one, will identify okay, the ability of the platelets to aggregate in the presence of your thrombin or your TRAP, thrombin-related activation peptide. Another instrument, we have here your multiplate. This one, try to measure also the platelet aggregation. So, only that, ang kanyang principle is your impedance aggregometry. So, just like your automated mga heme analyzer natin, it would have here the impedance, then the principle. But this one, try to incorporate other parameters like aggregation velocity, maximum aggregation, and the area under your aggregation curve. Okay, another instrument, we have here the platelet works. Well, the platelet works here try to measure the platelet aggregation as a percentage of the platelet aggregation, comparing here the aggregation of the platelets, the one collected in the EDDA versus the one collected with your agonist. I-compare mo lang siya. So, this one will also identify the patients on the antiplatelet therapy. So, pag ang patient natin is on the antiplatelet therapy, would have here the aggregation of 40 to 60% lang because again, you are taking drugs naman, di ba? So, that's antiplatelet which try to inhibit the platelet aggregation. So, therefore, expect here the patient to have here a decreased result in the platelet aggregation because the patient is on the antiplatelet therapy. Another instrument, PFA 100. This one, try to measure here your platelet aggregation. You could also identify your aspirin resistance with this type of the instrument. It try to measure platelet aggregation in terms of the closure time. The closure time is the time in which the aperture here try to cause occlusion upon addition of your after addition of your agonists. So there are two apertures of this instrument, one with incorporated with the collagen and your epinephrine. The other one is collagen and the ADP. Aspirin resistance. Pag ang kanyang closure time is much shorter compared to your therapeutic range. So pag sinabing aspirin resistant, walang activity, wala siyang effect. Okay, next we have your aspirin works. Okay, aspirin works try to measure your 11-dehydrothromboxane B2. 11-dehydrothromboxane B2 is your derivatives of your thromboxane A2. Okay, that's one is being converted from your thromboxane B2 with your enzyme dehydrothromboxane dehydrogenase. Converting that one to your 11-dehydrothromboxane B2. Okay, the sample used for this one is your urine sample. Okay, okay, the level of your 11-dehydrothromboxane B2 is increased in the following conditions. Ito yung mga thrombosis natin. Arteriosclerosis, stroke, your TIA or your transient ischemic attack, and we have also here your intracranial hemorrhage. Okay, on the other hand, ang 11-dehydrothromboxane beta is decreased pag ang patient natin is taking your aspirin. Remember that your aspirin, ano ginagawa ng aspirin natin? It try to prevent the conversion of your arachidonic acid to your prostaglandin. And therefore, wala kang maproproduce na thromboxane A2. At pag wala kang maproduce ng thromboxane A2, which is derivative niya lang naman ito, and therefore wala kang maproproduce din ito. That's if the patient is on aspirin therapy or taking aspirin. Aspirin resistance. Okay, ano ibig sabihin? Resistant to aspirin. Okay, even nag-take siya ng aspirin, walang activity. Walang effect ang aspirin natin. Kaya ang level nito ay still normal. So, signifying that the patient is your aspirin resistant. Because again, paano maging aspirin resistant? Because remember, ano ang activity ng aspirin natin? It tend to inhibit your platelet activation with inhibiting the production of your thromboxane A2. So ito sa patient natin, nag-take ng aspirin, okay, hindi siya bumaba ang kanyang aspirin o hindi bumaba ang kanyang thromboxane A2. And therefore, hindi din mababa ito. That would mean here that patient is not responding to the aspirin. Kaya normal ang kanyang result. That's your aspirin resistant. Okay, dapat kasi pag wala siyang resistant to the aspirin, ano mangyari? Bababa dapat ang result niya. Since resistant siya sa aspirin, so walang effect ang aspirin administration, therefore, ang result niya is still normal. That will identify your aspirin resistance. Okay, so thank you.